Good afternoon, everyone. Today we'll be presenting combined clinical rounds on behalf of Department of Hematology. Our case is of 24-year-old female resident of Delhi. She was a BDS final year student. She presented to AIIMS on 6th of August with complaints of high-grade fever, easy fatigability and pallor for past 14 days and abdominal pain for past 14 days. On evaluation, the fever was high-grade intermittent. The maximum temperature recorded was 103 degree Fahrenheit, not associated with chills or rigors, with no diurnal variation, with marginal reliefs with antipyretic. She also noticed gradual progressive paleness of face with easy fatigability. According to the patient, initially she was able to climb 4 flights of stairs easily. Now she developed fatigability on daily household activities. She had history of receiving 1 unit of PRBC transfusion 4 days back before coming to AIIMS. Patient also complained of abdominal pain, which was gradual in onset, generalized, intermittent, dull aching, non-radiating to any site, associated with nausea and loss of appetite. There was no aggravating or relieving factors for abdominal pain. There was no history of any unintentional weight loss, cough, diarrhea, or bleeding from any side. There was no history suggestive of any CNS involvement. There was no history of night sweats, bony pain, or any swelling noticed by the patient. There was no history of any alternative medicine intake. There was no history suggestive of any autoimmune disease. Personal, past, and family history was not significant. It was unremarkable. On clinical examination, the patient was conscious, cooperative. Important thing to notice was her ECOG PS was just 3 at the time of admission. Except for the tachycardia, rest of the vitals were stable. She had pallor, she had bilateral inguinal lymphadenopathy, largest measuring 2 into 2 centimeter. Lymph nodes were non-tender, mobile, firm in consistency. They were not adherent to the underlying structure or overlying skin. There was no icterus, cyanosis, clubbing, or pedal edema. There was no purpura, echinotic patches, skin rash, or any infiltration. There was no gum hypertrophy or sternal tenderness. There were no facial or skeletal abnormalities. There were no ulcer or any joint swelling. In systemic examination, the per abdomen examination was unremarkable except on palpation. Liver was palpable 4 centimeter below the costal margin and spleen was palpable 5 centimeter below the costal margin. Other systems like respiratory system, cardiovascular system, neurological system examination was unremarkable. So to summarize, a young girl with very short history of just 14 days with acute onset fever, weakness, requiring blood transfusion. She was pale, had bilateral inguinal lymphadenopathy, hepatosplenomegaly. So the differential we put were either it was some acute leukemia, it could be viral infection secondary to EBV or CMV, it could be HLH, or it could be disseminated tuberculosis. On further evaluation, we did a hemogram which revealed pancytopenia with severe anemia. The HB was 7.4 and that was after 1 unit of PRBC transfusion. Her TLC was just 330 with ANC with very severe neutropenia. ANC was just 107. Platelet count was 18,000 only, but there were no abnormal cell or blast seen on the peripheral smear. Her renal function tests were normal except mild derangement in liver function test. Her total bilirubin was 3.1 with direct fraction of 2.2. Her AST-ALT was elevated. We did a fever workup to know the cause of fever, which turned out to be negative. We did autoimmune workup, which was negative. However, LDH was elevated. It was 786 units. We did workup for HLH. All the lab diagnostic criteria for HLH except for serum ferritin were not in favor of diagnosis of HLH. So based on all these lab parameters, young female, high-grade fever with organomegaly, inguinal lymphadenopathy, pancytopenia and liver dysfunction, because CMV, EBV serology was negative, this diagnosis was ruled out. HLH was lower down the order because all the lab parameters were not favoring HLH. So we were left with 2 main diagnoses. Either it was acute leukemia, lymphoma, or it could be disseminated tuberculosis. We did, to know the focus of infection, we did CECT chest and abdomen, the findings of which will be discussed by Dr. Shreya, SR Radiodiagnosis.
Good afternoon, everyone. So I'll be presenting the imaging findings. We conducted a CECT chest and abdomen on 9th of August 2021. So on the lung window images, we can see that there are these centrilobular nodules which are seen in the right upper lobe. There were a few other discrete nodules in the left upper lobe, the right upper lobe, as well as the right middle lobe, which showed soft tissue nodules surrounded by a rim of ground glass opacity around it, which is suggestive of the halo sign. Now, this halo sign has been described typically with invasive pulmonary aspergillosis, but has also been seen in a lot of other fungal infections. The histopathological basis of this sign is that the invasive fungi they tend to involve the vessels, which results in thrombosis, followed by infarction of the tissue with surrounding ground glass opacity indicating hemorrhage. Moving on to the mediastinal, corresponding mediastinal window images, we can see that this nodule, which we saw on the lung window images, has a central hypodensity as compared to the periphery, which suggests necrosis. There was also mild pericardial effusion. On the mediastinal images, there was no lymphadenopathy or any pleural effusion. So moving on to the abdominal findings, the spleen as well as the liver both were enlarged. Now, there was this circumferential nodular type of gross thickening which was involving the proximal body as well as the fundus of the stomach, which is better appreciated on these curved MPR images when we can see this thickening in the region of the fundus and the body, whereas the rest of the body of the stomach and the antrum pylorus is normal. Other than that, there were few subcentimetric retroperitoneal lymph nodes, which did not show any necrosis. So, to summarize my findings, there were lung nodules with a halocyte, pericardial effusion, hepatosplenomegaly, a nodular thickening involving the fundus and body of the stomach, and borderline enlarged retroperitoneal lymph nodes. So, the differential diagnosis which we considered was a neoplastic growth along the wall of the stomach, possibly lymphoma because of the nodular type of thickening, along with active infection of lungs, likely fungal etiology prompted by the halo sign, or a second possibility of disseminated infection in explaining all these findings. I would now like to call Dr. Preeti to further proceed.
Good afternoon, everyone. So, the baseline of diagnostic marrow we received in the month of August 2020 with the clinical details of pancytopenia with splenomegaly. The TLC count was 200, and on differential count, there were no circulating bloods. The bone marrow aspirate was aparticulate, and the touch imprint smears were paucicellular. However, one of the touch imprint smears showed scattered monomorphic cells, and they were also present in aggregates. On the higher magnification, these monomorphic cells they had blastoid morphology. Bone marrow biopsy was cellular. It showed stromal edema. There was megakaryocytic hyperplasia with paratrabecular localization, and these megakaryocytes were dysplastic in morphology. Erythroid CD cells and myeloid CD cells were markedly reduced, and there was an interstitial excess of these immature cells. So on immunohistochemistry, these immature cells they were positive for CD20, TDT, CD10, and they were negative for CD34 and MPO. Immunohistochemistry for CD61 highlight an increase in megakaryocytes, including dysplastic megakaryocytes. So based on immunohistochemistry, a diagnosis of precursor B-cell acute lymphoblastic leukemia was given. So patient had hepatosplenomegaly, and on CT scan there was a thickened gastric mucosa along the upper greater curvature of the stomach. So we planned for upper GI endoscopy and gastric biopsy, which will be discussed by Dr. Deepika.
So first upper GI scopy was done on 25th of August, which showed a large deep ulcer with elevated margin present along the greater curvature of the fundus of the stomach, and there was a small subcentimetric nodule present in the body. Multiple biopsies were taken from ulcer and this subcentimetric nodule. We sent the biopsy sample for histopathological examination which showed autolyzed fragment with non-specific inflammatory changes. There were no atypical cells or fungus seen in these specimens. We had also sent the sample for direct microscopy using fluorescent brightener, chalcofluor white, which showed presence of septate and aseptate hyphae in the gastric biopsy specimen. Thus, we had a diagnosis of gastric mucormycosis. And the best part was, we sent the sample on 26th of August and we got the report on 27th itself. Then yes, we had a diagnosis now. It was precursor B ALL with disseminated mucormycosis and aspergillosis, both gastrointestinal tract and lungs were involved. Now we were in the middle of some big trouble because steroids are an integral part of treatment of ALL, and giving steroids in a patient who is having gastric ulcer is potentially lethal. If we keep this ALL untreated, it is life-threatening, and giving chemotherapy in a patient who is having disseminated fungal infection, it is potentially life-threatening. But during these fearsome times, we noticed that there was spontaneous improvement in blood counts of the patient. Her hemoglobin started improving, her TLC, ANC count started recovering on its own. Her platelet also recovered. So she was admitted on 6th of August. On 9th, the bone marrow was done. On 10th, she was started on voriconazole after CECT test suggestive of fungal infection. On 19th of August, because of liver dysfunction secondary to voriconazole plus poor response to voriconazole, the patient was shifted on liposomal amphotericin B. We got the report of BALL via immuno-IHC and mucormycosis on gastric biopsy on around 28th of August. So during this time, we had already started liposomal amphotericin B. We did a bone marrow after 7 days.
So the second bone marrow aspirate we received on 9th of September with details of BALL with mucormycosis. So at this time, the patient was not started on leukemia-directed therapy. Her TLC count increased from 200 to 2000. PS showed neutrophilic predominance with no circulating blast. Bone marrow aspirate was cellular with 4% blast. So at this time point, the bone marrow was in morphological remission. So this is a spontaneous remission since the patient was not started on leukemia-directed therapy. However, on immunophenotyping of the aspirate sample, on gating CD19 positive cells on a mononuclear gate after excluding the plasma cells, there was this small population which was bright positive for CD10, positive for 38, negative for 34, positive for 73, CD20. So there was a residual disease present at a level of 0.23%, which is very significant, and it signifies that the patient might relapse in near future, though the marrow was in morphological remission. So this morphological remission provided a window to start with the antifungal treatment, and the treatment part will be discussed by Dr.
This spontaneous remission gave us a window to treat the gastric mucormycosis, and the patient was started. Approved therapy for gastrointestinal mucormycosis is either AIIMS in azoles, only isavuconazole is approved as first-line drug. We started our patient on liposomal amphotericin B at 5 mg per kg per day. It was started from 19th of August. We repeated an upper GI scopy after 14 days of treatment with liposomal amphotericin B, which showed a significant improving in gastric ulcer. On upper GI scopy, there was very small ulcer of size less than 1 centimeter along the greater curvature of the stomach, and as compared to the previous endoscopy, there was a significant healing. So we knew we were going in the right direction. Patient was given 28 days of treatment with liposomal amphotericin B, and there was complete healing of gastric ulcer after that. Once the ulcer was healed, we started her on augmented BFM induction protocol from 14th of September. She tolerated chemotherapy well, and rest of the induction was uneventful. Her end of induction bone marrow was in morphological remission, and this time the MRD was also negative. This is the timeline of events. The patient was symptomatic from end of July. She presented to AIIMS on 6th of August. On 9th, the bone marrow was done. On 19th, because of liver dysfunction and poor response to voriconazole, and with high suspicion of mucormycosis, she was started on liposomal amphotericin B. On 25th, we did an upper GI endoscopy and gastric biopsies were taken. On 27th, we got the result of IHC. It was suggestive of BALL. We also got results of gastric biopsy, which was suggestive of GI mucormycosis. Fortunately, on 9th of September, around 9th of September, she went into spontaneous remission and she was started on augmented BFM from 14th of September. Now we would like to discuss two rare events which occurred in this patient. One was spontaneous remission and other was successful outcome despite having GI mucormycosis with ALL. First, spontaneous remission will be discussed by Dr. Preeti.
So this spontaneous remission was a rare in this patient since it provided a window to start the antifungal treatment in the face of a fearsome disease. So it is a rare but notable phenomenon, and it is defined as the disappearance of a malignant tumor in the absence of treatment or in the presence of therapy which is considered inadequate to exert a clinical influence on the neoplastic disease. The phenomenon is also known as Saint Peregrine tumor. This young priest developed a large bone tumor requiring amputation. So on the night preceding the surgery, he prayed intensely and woke up without any trace of tumor. So is it a miracle? No. There are scientific explanations to it. So cases of spontaneous remission have appeared in the medical literature since the early 19th century. Here are the various case reports and case series on spontaneous remission, including solid malignancies. Here are the various reviews on the spontaneous remission. Talking about the spontaneous remission in ALL, many cases have been reported in acute myeloid leukemia and rarely for the adult ALL. All the documented cases were only transient, as seen in our case also. Chemotherapy should not be deferred despite apparent spontaneous remission. So here is a case report from our department of a 46-year-old male with acute lymphoblastic leukemia who went into spontaneous remission. This was published in 2015. So a case report in 1993 by Hirschberg and Oregon, they described a pattern of feverish or septic disease followed by quick but transient remission. So what are the possible mechanisms for spontaneous regression? Number one, the role of cytotoxic immune response. Cytokines such as TNF-alpha or interferon gamma, they induce indirect and direct anti-tumor immune responses. Second, tumor remission may be due to a genetic crisis due to inhibition of telomerase associated with the cellular immortality and tumorigenesis. Third, programmed cell death is also involved in spontaneous regression as the cytokine signals may induce leukemia cells to differentiate or induce them to die naturally. Fourth, high stress may raise the levels of natural steroids and cause temporary regression. So, gastric mucormycosis part by Dr. Deepika.
Mucormycosis, it's a serious infection, life-threatening, caused by fungi belonging to class Lagomycetes of order Mucorales. It is the third most common invasive fungal infection after aspergillosis and candidiasis. The thing is, the spores of mucormycosis are ubiquitous in nature and every human being has ample exposure to these spores on day-to-day basis. But the incidence of mucormycosis is very rare, implying that the innate immunity is very effective in controlling the infection. Given the increasing incidence of malignancies, more and more people opting for chemotherapy nowadays and transplantation, plus an ongoing epidemic of obesity and diabetes, the overall incidence of mucormycosis is increasing globally over the past 2 decades, particularly in France, Belgium, Switzerland, and India. In India, the estimated prevalence of mucormycosis is 140 cases per million population. According to the various studies done by various Indian authors, the most common site of involvement is rhino-orbital cerebral, which was seen in the patients who are diabetic. We can see the gastrointestinal mucormycosis is very rare, and the overall incidence of GI mucormycosis is around 2 to 11% only. But because of the increasing incidence of malignancies and most patients taking chemotherapy, the incidence of GI mucormycosis is increasing, and we as a clinician are bound to face these increased mucormycosis cases in the future more frequently. The important thing about gastrointestinal mucormycosis is that only 25% of the cases they are diagnosed ante-mortem. Gastrointestinal mucormycosis, though rare, may occur due to the ingestion of contaminated food or drink. Historically, it was seen in premature infants, those with severe malnutrition or undergoing peritoneal dialysis. Then, after 19, it was seen in patients who are immunocompromised, like those who were diabetic, on chemotherapy, on steroids. But now it is also seen in immunocompetent adults who are admitted to ICU or who are having prolonged hospitalization or major surgery. So, high index of suspicion is required for diagnosis of GI mucormycosis. If the patient is having risk factor, clinical features, then we should use early use of imagings like CT and MRI. We should suspect GI mucormycosis and start preemptive treatment as fast as we can. The increased morbidity and mortality which is associated with GI mucormycosis is because of the non-specific presentation. It presents with non-specific abdominal pain and distension associated with nausea and vomiting. Therefore, it is very difficult to diagnose unless you have a high index of suspicion. Patient may present with fever, hematemesis, or hematochezia. So most of the patient presents when there is GI ulceration and perforation, and they develop peritonitis, sepsis, and hemorrhagic shock. Definitive diagnosis can be made by biopsy of the suspected area during surgery or after endoscopy. As far as site is concerned, stomach is the most common site involved, followed by colon, small intestine, and esophagus. One of the studies showed that delaying liposomal amphotericin B-based therapy for the treatment of GI mucormycosis in the patient who are having hematological malignancies for more than equal to 6 days resulted in almost twofold increased mortality at 12 weeks. So every delay has a dangerous end. Present status of the patient: after her induction, she completed her other intensive phases of ALL chemotherapy well. At present, she is on maintenance phase of her chemotherapy, doing well and preparing for her MDS entrance exam. So, take-home message is GI mucormycosis is rare. Though the incidents are increasing nowadays, it requires a high index of suspicion, early recognition of non-specific symptoms which can be life-threatening, early initiation of antifungal therapy if you have a suspicion of mucormycosis. As far as spontaneous regression is concerned, it is rare, but it is a notable phenomenon. All documented cases of spontaneous remission were only transient, therefore they need to be treated, and chemotherapy should not be stopped despite your patient being in apparent SR. All this was possible because of the teamwork. We would like to thank all the departments who made this outcome possible. Thank you.
So teamwork indeed. Many of the department came into helping this patient. So what we have in this, we commonly see fungal infections in our patient at diagnosis. This is not uncommon, but presence of fungal infection at diagnosis poses the patient severe risk of infection during the induction chemotherapy, and the outcomes are not great. Less than half of these patients survive the induction. Luckily, what happened, gastric mucormycosis, as has been highlighted, is a rare site for a mucor infection. Only 2 to 10% of the overall cases have a GI site. Luckily for this patient, she went into spontaneous remission, another rare phenomena occurring. We were able to give her antifungal therapy for prolonged time. By the time her ulcer had healed completely, and we were able to start on the proper therapy, including steroids. We all know steroids can cause GI ulcer, and in the setting of an ulcer, this might lead to perforation. So, good for us, good for the patient that we are able to give the complete therapy to her. We have Dr. Gagandi from microbiology and Dr. Deepak Gunjan from the gastroenterology department. I'd like to invite inputs from them on this piece.
Thank you. So, I think the thing that I like to highlight here is the importance of verification. That is one of our major goals, so we can see the fungus there, and thus using a calculator pH has much more sensitivity than a plain pH. Because the turnaround time is very short. And I think it corroborates well because the culture was not positive.
Yes, sir.
Yes. Probably because the MVP had already started progressing the reason why the fungus was already known by by the time it came to us. So probably that is why it wasn't recovered. But just I want to ask this because we had reported it as septate plus aseptate. So probably at that site there was both there were mucorales as well as aspergillus on that site. We should not ignore that. Probably because of the immune compromised state.
Both the infections are, yes.
Although mucormycosis much more virulent and progressed very early. I think that should not be noted. Probably we still not because the lesion in the lung were never sampled.
Yeah.
Again, we don't know whether they were aspergillus or mucorales. Or I think galactomannan was fine.
Galactomannan was negative, and usually in such severe thrombocytopenia, many of us, our patients are not able to undergo lung biopsy or PAL. Dr. Deepak sir.
So upon endoscopy, usually it is not very characteristic finding. Suspect only on biopsy. In the fungal infection. Otherwise, there is no characteristic finding.
Now I invite the questions from the house.
This spontaneous solution is clear. Is there a possibility that the cytokines some this from fungus helps in those factor? Apart from this, is there other
Sir, mainly the induction chemotherapy of AL and that in that steroids form a major backbone, and the doses and schedule could be different, but steroids are an integral part of AL induction. Yes, sir. It's a multi-drug regime, so there are 4 drugs which are used in the AL induction therapy, and subsequently there are other drugs which can be given. But yeah, and sir, regarding your first question, so that's a possibility. So the 2 cases which we have in a department, the first one had infective endocarditis at that time, and this patient had this mucormycosis. So
this is not only the same essential and also so that right. So congratulations, you started the whole 8 days before the hypothesis. So which may make a difference for you. I'm also interested in the spontaneous regression and your comment that chemotherapy will not be deferred. So we wait for the ALL to come back before we give the chemotherapy, or we just go ahead.
So we
the reason why I ask is that might be some go into stable, sustained spontaneous. We don't find out about them because they don't come back to us. So would it make sense to wait till the counts go up again before continuing the position plan of chemotherapy?
So the median time to relapse in such cases is around 4 to 6 weeks only. There are reports that the remissions can be longer, but median time is around 4 to 6 weeks only, and most of the cases they come back by that time. So what we have followed in the 2 cases is that by the time the patient has stabilized, we start them on therapy. That is kind of a consensus across now.
Before the counts go up.
Yes.
What is important what is important when we realize is that every time the lowest screen has to be taken. The decision has to be tailored according to three spontaneous remissions have been documented in patients who develop severe infections, be it bacterial, viral, or associated knowledge is that leads to air to inflammation. Spontaneous remissions are being reported more in lymphoblastic. On the other side, delay in treatment has not been shown to have any. So, take time for the patient to stabilize and treatment has to be started before the disease relapses into vengeance. The value of the consensus guidelines there.
What could be the source? Because sinuses were not involved. Any bacteria. Improve respiratory route.
That can be said probably for the immunocompetent patient, but for immunocompromised patient like this, these are possible. I think we can finish and start with the next CCF of the ENT department.
So we'll start with the second case. Good afternoon, all. The second case we are having is a purely surgical cases, and this is how we manage in our department the facial nerve paralysis, which is mainly we are focusing on the surgical management of facial nerve paralysis. So I'll ask Dr. Harsha to come and discuss the case.
Very good afternoon, everyone, respected teachers and my dear colleagues. Today, on behalf of ENT department, will be presenting you a case with title "Restoring the Smiling Face: Surgical Reanimation for Facial Paralysis." So, to brief you with the introduction, as we know that the facial palsy is one of the common entity that we come across in our practice, which almost affects about 1 in 2,500 people every year, and there is a chance that 1 in a lifetime of in a 60 people can have facial palsy, and the facial paralysis here causes a very great affects the quality of life very greatly, because it causes a obvious asymmetry of the face, and also very importantly there may be hampering of the lubrication of the eye, which in turn may endanger the eye to cause blindness as well. So currently, there is no one operation that can afford restitutio ad integrum, that is restoration of the integration of the paralyzed face to its pre-paralyzed condition. But as a surgeon, our efforts are to be directed at minimizing the pre-existing morbidity such that the patient has an acceptable and a quality life. So here this is a picture photograph showing a patient with a severe facial nerve paralysis on the left side. Here we can see that as a consequence of which there is a very difficulty in closing the eye, and there is dry eye, and also flattening of the wrinkles of the forehead. That is, the patient not able to raise the eyebrow on the affected side, and also an obvious asymmetry with deviation of the angle of the mouth towards the normal side, that is towards the right side and here, and there is a loss of nasolabial fold on the left side. And also there is a distorted smile because of these things, and anesthesia over the external auditory canal is also noted in these patients. So it has been noted that even once a patient, like for example, if a patient had a facial paralysis because of facial nerve schwannoma or an acoustic neuroma, and even if we treat these patients, such patients have a very low or a low facial disability index or scores. And also it's been reported that in all those patients with facial paralysis, post-surgically treated, there may be a chance that of about 100%, in about 100 people, 31% may have anxiety and depression symptoms. So these things in turn cause a very significant psychosocial distress in these patients because they are not able to communicate with emotional cues, which is very important. So just to brush up our memory, these are the causes for the facial paralysis. One of the main causes is idiopathic and congenital causes. Wherein idiopathic, we have Bell's palsy, which we see in day-to-day practice, and also Mobius syndrome is such that in children are also affected because of the congenital condition that facial nerve and related musculatures are very underdeveloped. And we have infectious and inflammatory causes, wherein the most common are herpes zoster virus infection, and also sarcoidosis, and also the very important in our practice, that is chronic otitis media. Chronic otitis media usually causes facial palsy because of its close proximity of the course of the facial nerve in the ear. So, and trauma and neoplastic conditions, wherein trauma, we say that there are two types of trauma here. One is the patient having a trauma because of an accident, or so having a temporal bone fracture or any other skull fractures. And idiopathic trauma is nothing but iatrogenic, is nothing but when the surgeon or doctor induces a trauma to the facial nerve. And also certain conditions such as demyelinating disorders and other CNS stroke condition causing upper motor neuron paralysis of the facial nerve. So each of these conditions has to be properly evaluated, and the management may differ in each of these. So here we bring our experience of case wherein patient has had a long-term paralysis of the facial nerve and has not. How do we go about in such scenarios? So here's the details, wherein 21-year-old female patient who's a known case of left-sided facial nerve schwannoma, which is a benign nerve sheath tumor involving the mastoid part of the facial nerve, wherein this patient has already underwent left-sided transmastoid approach tumor excision about 6 months ago before our presentation in our hospital itself. And this involves excision of the tumor incompletely so that the facial nerve is not in continuum at the mastoid part of the ear. So because of which patient had presented with us in a persistent complaints of left-sided facial weakness and an inability to significantly close the eye. So here the thing we need to notice here is the patient, before having this disease, she had facial palsy as a main complaint before this in presentation as well. However, there was no worsening after the surgery. So patient did not have any other comorbid significant illnesses in the past. She was a student and resident of Uttarakhand, and on examination, her general physical examination and systemic parameters were within normal. And coming to the local, as I have said, that 6 months back patient had a surgery, a post-oral approach surgery, wherein post-oral scar was well healed and the mastoid cavity was also well healed with no clinical signs suggestive of any recurrence or any residual disease. However, audiometry showed that the right ear was normal and the left ear had a very moderate conductive hearing loss because of the surgical aspect. So this is the photograph of the patient. On towards the left hand side, we can see that the patient at rest did not have a very gross facial asymmetry as noted, but with effort she had, however, an incomplete eye closure. Almost half the eye is not closing properly, and an obvious distortion of the angle of mouth because of the weakness on the left side. So she had a House-Brackman staging grade 5 paralysis, which is significant. In the staging system, grade 6 is the severe one. And here what we need to notice here is this facial paralysis right from the onset of the disease was about 1.5 year duration. And an MRI showed that there was no residual disease at this point of time. So this indicates that we were good to go ahead with restoring this. So this was a nerve conduction study or an electromyography of the facial nerve and the related muscles. So here what we need to notice here is after a variable period of about 18 to 24 months. This duration is very important because beyond 24 months, that is 2 years, it is noted that the muscle of the faces, even though the nerve supply is not there, they may undergo atrophy, thereby not giving any chance for the restoration. So thus, before 24 months to 2 years of onset of the facial nerve impairment, a neural stimulus is restored that can restore the function of the facial nerve as well. So here the report showed that there was some fibrillation potential and nerve potentials noted in the affected side as well. So to summarize, we had a patient with significant left-sided grade 5 facial palsy with post-excision status of facial nerve schwannoma and a probable absent distal stump of the facial nerve due to the surgery. So there was no chance of restoring the facial nerve in its continuum, and there were presence of fibrillation potentials on EMG, and the duration of prior surgery and the intervention was 6 months. With this, we had planned for a left-sided facial and mesenteric nerve anastomosis under general anesthesia. So I want your attention to be on the figure B here. This is a lateral view of the face with facial musculature and the facial nerve course drawn out here. So the lower arrow that is pointed out is the facial nerve, which is the main trunk divided into the known 5 branches, which respectively supplies all the facial nerve musculature. And the other arrow here that is being pointed out here is another nerve called as a mesenteric nerve. This is a third branch of trigeminal nerve, which in turn supplies the muscles of mastication. That is mainly the masseter muscle, so which is also in proximity with the parotid. So now what happens here is the facial and mesenteric nerve anastomosis, because of the close proximity here, that proximity means in front of the parotid in a region bounded by a triangle shape like here, like posteriorly the condyle of the mandible and anteriorly the coronac process of the mandible and a notch. They form a triangular fossa, which is overlaid by the masseter muscle. So after we dissect this masseter muscle, we can easily find out this mesenteric nerve. So this surgery has its principle that if we adequately mobilize the facial nerve here and tilt it facial nerve anteriorly and get in proximity with the mesenteric nerve, we can anastomose it. Thereby, the motor supply is derived from the third branch of the trigeminal nerve. So here, if there is a less length, then we can use a greater auricular nerve as a cable grafting in restoring the continuation and re-anastomosing it. So with this, this is the surgical picture that I would like to show. So in approaching this surgery, we give a usual parotidectomy incision, which is modified Blair's incision that we give for any good parotidectomy. And we elevate the submuscular aponeurotic flap until anterior border of the masseter muscle. And after noting after elevation of the flap, we go ahead with identification of the facial nerve here. This is the facial nerve main trunk with the usual landmarks that we follow for the parotid surgery, like the ear tragus of the cartilage of the EAC and the stylomastid, the suture line and everything. And this is the facial trunk. After identifying the facial trunk, so the facial trunk is transected at the distalmost part near to the stylomastid front. And after that, we explore the masseter muscle between the intermediate and the deep heads of the masseter. We find this mesenteric nerve. Once this mesenteric nerve is identified, it is also transected at its distal part, and they are brought together, close together. This is the facial nerve and this is the masseter nerve. By using a microscope, we microscope and we anastomose these two nerves, and then we close the incision. So this is the results showing the results of this surgery. The extreme left is a pre-op, and post of 5 months, we can see that the patient has got good angle of mouth action on the left side, but eye closure is not very adequate. But as we proceed for 1 year follow-up, there is a almost acceptable good improvement in the facial nerve function, and a good smile has been given in an acceptable level. And also, in addition to that, muscle eye closure has also been significantly achieved well. So, with this, I invite upon Dr. Chiram Amit sir to initiate the discussion. Thank you.
Thank you, Dr. Harsha. So, for the facial paralysis, this is mainly for the traumatic or for the after tumor excision in which we have excised part of the nerve. First, we have to know that whether we can find the distal segment. If we can have the distal segment, we can approximate the nerve and we can do the end-to-end closure during the surgical procedure itself. Or if we find the distal segment and the resection of the nerve is more, then we can use a cable graft like the sural nerve or the greater auricular nerve. But many times we don't have that situations, and in these patients, we can find some other source for the supply of the muscles, like we can use a mesenteric nerve. Previously, hypoglossal nerve was used, ANSA was used, and we can power these muscles by using some different nerves. The issue with these nerves is, though we can have some movement, the patient is difficult to develop the spontaneous smile. So since they may be smiling voluntarily, but when they go into a spontaneous smile, they will still have that facial weakness symptoms. Or to overcome that, we have another procedure, what is known as a cross-facial paralysis. So we power the muscle using some other nerve like the sural nerve, taking supply from the opposite facial nerve so they can have some symmetrical smile. Among all these procedures, which we use some other nerves to power the facial muscle, mesenteric nerve is the only one which can give even spontaneous smile. That is, we can achieve in up to 25%, though the reason is not actually known. It is thought to have the close proximity of the facial nerve nucleus with the mesenteric nerve nucleus. So that is one hypothesis which people have given. So in up to some 25% of this patient, they can still have spontaneous smile. So this we usually do for these patients which the muscle is still functional. That is, we prefer to do it within 1.5 years or within 2 years. What if the patient comes late, that is more than 2 years, in which we expect that the muscle has already grown into atrophy? Still, we have options for these patients, like we can use some other muscle which are still functioning to achieve some form of movement of face on the side of the facial weakness. That is, we can use a local muscle that is a temporalis muscle. We can use a tendon to anchor into the angle of the mouth so that the patient can achieve smile by clenching the teeth. Or we can use free flap. This is the most commonly done for the younger patient like the Mobius syndrome, in which we can use a functional muscle, free flap. We take the gracilis muscle, we anchor in the angle of the smile and power the muscle with the facial nerve, or we power it with the mesenteric nerve. For the eye closure, what we usually do in our department is a gold weight implant. That is, we put the implant in the upper eyelid so that they can have that adequate closure. Or we can use a temporalis, part of the temporalis muscle, to sling it and then help in closing the eye. So, for example, if we have this thing, this is a temporalis tendon transfer. This is a patient with in which the palsy is more than 2 years, in which we take this temporalis tendon and then anchor to the muscle in the orbicularis oris, superior and the inferior part, so, along the angle of the smile. So in this we can achieve even in this patient we have used this gold weight implant also. In this we can use, when the patient cleans the teeth, he can have that some form of movement, but this is totally different muscle. That is a temporalis muscle we are using it, and they can also avoid that sagging of the face on the same side. So in the gold weight implant, what we do is we use the first we measure it by using a dummy implant, stick it, and then know the exact weight of the implant. And then we can put the implant in the upper eyelid, just above, superior to the tarsal plate, and so that when the patient closes the eye, the closure is complete. So thank you all. So you can, any comments or any questions you want to ask, I will be happy to take the questions. Yes, sir. It is a goal. So what we use is first we measure how much weight it is required, and we have contacted some of the goldsmiths so that they can make the actual how much is the curvature of the template. What we have shown is our postoperative department help us in giving this template. So according to the curvature of the eyeball, we make that implant and then we put it in the skin pocket in the upper eye. No, this is not 3D printing. They do it by the mold cast.
And then some more.
So we have a contact with the gold. So they help us in making that.
So how much very
So I actually don't know the exact amount. It's affordable, sir. It's not that cost.
and what about reaction?
So there is not much problem which we have encountered. Still, the patient when they use this implant, it's not that the eye will be closed but if you see while the patient is lying down, the eye is still going to open. So the patient still needs to tape it during sleep. No, it's not. It means we implanted and it's like it's inert, so it doesn't have that much reaction. If it is problematic, we can remove it. Yes. So first, when we take out this temporalis muscle, this is for the long-standing weak paralysis. First, the condyle, and then we can take. But the muscle it doesn't reach. Sometimes it will not reach that much. So we can use facial. So we can use this facial artery, split it into two, and then first superiorly we can suture to the facial artery, and then we can bridge that gap.